I believe we are very successful today, and to have those two lectures, and the viewer, I'm sure the attendees today enjoyed too much as I did, and we are looking forward to the third lecture. Dr. Walid Alhabashy, he is my excellent colleague working with me in Ireland. Dr. Walid is you know, a very good achiever. He has a master degree, PhD, and EDIC exam, and the FCI exam, and finally he got board certification in echocardiography. Dr. Walid is, as I told you, he is not only anesthetist and intensivist, he is multitasking, and he is the main organizing for this group, mega course online for anesthesiology and intensive care and the vein medicine. And he is behind all the high-tech and organization for this course. I would like to welcome Dr. Walid Alhabashy for his exceptional lecture, Anesthesia for Fracture Femur, Pathway of the Anesthesia. Welcome, Dr. Walid.
Thanks so much, Prof. Saad, for this introduction, and it's my pleasure to be with colleagues here and seniors who examined me one day in my MD. So to make it easy for our attendees today, we're talking about a simple topic, yet very important in all anesthesia exams. Let me start by introducing myself. My name is Walid Alhabashy. I work as an anesthesia consultant in Egypt, but currently as a senior registrar in Ireland in the Mater University Hospital in Ireland, one of the biggest ones here. I am presenting today the AAGBI guidelines on the fracture neck of femur or hip fractures. It is a different name for it. And it's not only just an exam question, but a challenging topic, despite it looks simple, but believe me, there is a lot behind the question. Due to difference mainly in the systems between European countries and most of the Middle East countries, we don't have that rigid system, and you will see when we go through this one. So if you are taking any European exam, they are expecting you to be aware, at least aware of the system they are running the show with. I remember my very first week in Ireland in Cork University Hospital, and they put me in the orthopedics list. At this moment, I was not practicing orthopedic lists for a good while. Then the consultant anesthetist working with me in this list asked me, is it an extracapsular or intracapsular fracture? And then I was like, oh my God. So is there a difference I should be aware of from the anesthetics point of view? Because they don't ask unless it is something relevant to our practice. So let's go and see during this one what will be the story of these orthopedic fractures in hip and hip fractures. My aim, if you are familiar with this photo here, this is the very common and famous videotaped discussion between an orthopedics surgeon and an anesthetist. So I'm not going to discuss this debate today between the orthopedician and anesthetist. Is not my objective, but the lecture want to emphasize the multidisciplinary approach as well, and highlight my role as an anesthetist in this team. So we'll go through the objectives together. So is it an essential topic to study? Yes, definitely is, and you will know why in the next slide. Clinical scenario-based discussion, so we'll give you a case and discuss this case in details, but we have to highlight some anatomical facts while we are on the go together, and we will highlight and emphasize what are the facilities I am required to have in my hospital to run this type of surgeries. Then definitely the perioperative anesthetic management, so history examination or preoperative assessment, then induction and maintenance, intraoperative assessment, and then recovery of the patient. We'll go through all of that during this lecture. So the first question, is it a legitimate question, or is this a good case to be discussed? Yes, definitely it is. It's firstly because if you're preparing an exam, as I said, you have to be aware of European standards or the AAGBI guidelines, which is the most major standard of care now in the whole world. So it's almost for everybody to know about it. If you're covering anesthesia emergency list as a clinical anesthetist, you still need to know how to prioritize this case. It should be like an emergency or urgent or just elective or postpone it for a few days. So I need to know that. So this is the first one. It's an exam question. Secondly, it's a really challenging decision to proceed or cancel, and on what basis. This is a daily scenario that we face every day in our life. A patient with hip fractures coming for fixation, the orthopedician is going to push towards the theater, and you're trying to push to postpone to optimize the patient more. So what is the right thing? Is there any guidelines for that? It depends on if you're a junior and getting this case after the middle of the night, should I proceed or cancel it or postpone it till the morning? If I'm a senior anesthetist during the on-call and I still need to look at the big picture, how to prioritize this case, so it's still an important question. It's a multidisciplinary team discussion, and you need to document that in your notes. So if you're documenting your logbook as a trainee, I could say you can go back to my lecture on document on the go. They will ask on multidisciplinary team approaches in your documentations, and this is a very good case to do so, because you will discuss, as you will see in the coming slides, a lot of people with this case. So there's a lot of people in the team discussing this case. So this is a very good case to document because it's a multidisciplinary team approach. High mortality and morbidity, so it still sticks to my whole life's idea about medicine and anesthesia, saving lives. So that's why I selected this case. Like, if you postpone this case more than 48 hours, all the statistics from the United Kingdom says that there's a higher mortality and morbidity, and the morbidities are in the term of pneumonias, in the term of urinary tract infection, DVTs, pulmonary embolisms. There is a lot in the background may happen if you postpone this case more than 48 hours. So that's why you should really stick to maximum of 48 hours to do this procedure as fast as you can. So back to this dilemma, should I cancel this case because it is premature decision, or it is premature to be admitted to operating theater, or delay the case with this morbidity and mortality increase just to fulfill the patient optimization and referrals? So let's go clinical. This is a 68-year-old female patient. She has a history of non-insulin dependent diabetes. She has ischemic heart disease. She had an AFib. She's hypertensive. She's on regular warfarin 2 milligrams per day. And she slept while she was making wudu on the sink in the toilet at home. And on arrival to the emergency department, she arrived at 8 o'clock in the morning. She was fasting. She was in severe pain. Her systolic blood pressure was 195. Her heart rate was 115. She has an atrial fibrillation. Still, that's her history. She has a saturation of 94%. Her random sugar was 11.5 millimoles. If you're using milligrams, it's around 207 milligrams. So despite being fasting in Ramadan, her blood sugar was 11.5. I believe there is some sort of stress in the background here, but I cannot know. So the orthopedic registrar is asking to bring her to today's orthopedics list towards the end of the list, so at like 3:30 p.m. time. So it's still good time to try to optimize this patient and ask for investigations that you want. So what do you think? Should we admit her to today's list or postpone her to tomorrow's list? So at least 24 hours after that. So let's go about, before we discuss this clinical scenario, about some facts. Some facts about hip fractures or neck of femur fracture. Like, more than 50,000 surgeries in the United Kingdom per year is happening, which carries more than 10% or around 10% of mortality in the first month, and definitely more in the first year. The anatomy of the fracture neck of femur makes a lot of our understanding and decision making, so you need to be aware of that fracture neck femur, how and when and where it goes. So this is the intertrochanteric line. If you see my cursor here, so this is greater trochanter and this is the lesser trochanter. This is the intertrochanteric line. So anything is above, or any fracture above the intertrochanteric line, we call it intracapsular or intercervical fracture. Anything below this intertrochanteric line, Okay, this is the extra capsular. Does it make any sense? Yes, it does, because it makes a lot in decision making here. Intracapsular is treated with replacement of the neck of femur if it's displaced the fracture. If it is not displaced the fracture, you may do a dynamic hip screw and give the chance to this femur to survive. That is if it is less than 48 hours. After 48 hours, the head of femur get a vascular necrosis because the blood supply to the head of the femur and the neck of the femur is coming from the femoral artery and giving all the branches here in the neck of femur going to the head or the acetabulum. If you miss this blood supply, this will in few days become has a vascular necrosis or become necrotic. And there is no point to repair it with a dynamic screw, so or any screwing. So this is a decision making. So you have to understand what is above intertrochanteric line. Is it displaced or not displaced? This is the data that you need to understand from the orthopedics. If you get a phone call, I have a fractured neck femur, I want to push to the emergency list. Okay, so what are the chances of this one to survive? What is the displacement? Is it displaced or not displaced? So there's a classification for that, which is 4 stages: 1 and 2, 3 and 4. 1 and 2 are intracapsular, non-displaced. 3 and 4 is subtrochanteric or extracapsular, and they are 1 and 2 is non-displaced, and 3 and 4 is a displaced fractures. And you can go to this classification. I'm not really keen to know it myself, but like if you know the principle, that will be more than enough in our exams. The blood supply, as we said, the femoral artery is coming from here and then supplying all this neck of femur and the acetabulum. Then if you lose this blood supply, you lose the femur head. So let's go now and discuss what are the facilities I should be happy to have in my hospital. What is the minimum facility I should be happy to have in my hospital? It is a multidisciplinary team, as I said. So it's the management between the general practitioner or the GP, the community nurses, the emergency physicians or staff, the bed managers, the orthopedic surgeon, the senior anesthetist, the orthogeriatrician, the physiotherapist, the social worker, the rehabilitation service, the trauma coordinator. And believe me, I had found all this team on board with these cases in Ireland. So it is not just written in the books. That's why they are expecting you to know about this multidisciplinary team approach. Who is coordinating all that? It is a trauma coordinator. You're just one member of the team, but you need to get the input from everybody, and that's happening through the trauma coordinator. Once the patient is arriving to the hospital, he has a planned care pathway. So he has a prioritized anesthetist, prioritized orthopedician. There is a well-written protocol to manage every single issue about this patient. So if he's diabetic, what is the fasting sugar should be, how to control the blood sugar, how to reverse anticoagulation if I need to. So it's a protocolized approach. It's written. You don't have to do any brainstorming or use your personal previous experience to manage this patient. It should be, and it's always happening in Europe, that you have a protected trauma list. So there's a trauma list, one fully dedicated theater for trauma on every day. And if your emergency theater is working and you got a life or limb, this is the only time you're allowed to use the trauma list theater. So if you got this kind of trauma, it's in a pathway. You don't have to worry about making a theater for it. This theater is protected theater in most of the European countries. To get an idea on how important these surgeries are, the recommendation from the AAGBI guidelines, it is not to be delivered, service is not to be delivered with less than a consultant in the service. So it should be a consultant because of old age, multiple comorbidities, higher mortalities in this age group, up to 10%. So again, it should be the consultant or at least senior registrar with a consultant on board. So you can put this patient asleep if you involve with your consultant, but the recommendation is so clear about that one. Operating department is very important to adjust a few things before I push this patient from ED to theaters. I should warm the theater to a degree, temperature degree of 20 to 23. Humidity will be 50 to 60%. And I'm not going to discuss humidity and temperature details. I will leave that to Dr. Mohammed Al-Shourbagi. He will discuss that in full details and what's the impact of hypothermia and poor humidity in our patient management. It's really serious and very deleterious effects. You have to take care of that. It's not a minor issue. And please expect that to come into your exams. So let's go to preoperative clinical management. Analgesia. So once the patient arrives to ED, you have to give him a painkiller. His agonizing pain that may be pushing his blood pressure up and tachycardia up. As you have seen in our scenario, I need to rule out pain as the cause of hypertension, high blood sugar, and tachycardia. So we have to treat this one. You have the options to give him some IV narcotics like a small dose of fentanyl, but be cautious with this age group. It is like old age, it may cause some respiratory depression or delirium or depressed level of consciousness. You have to be careful. Or you can give him some PO medications as analgesia. We don't jump definitely to the narcotics in the first instance, but your analgesia and painkillers are really limited, because in this age group, 68, maybe good 68 or bad 68 with multiple comorbidities, his kidneys could be a problem. So you cannot give him non-steroidals. You cannot give him a lot of narcotics like morphine. You cannot be like generous with it. So be cautious. I can say fascia iliaca block is the magic solution. There's a lot of emergency physicians now learned how to do the fascia iliaca block, and they do that on emergency room with like they need to attend 3 to 6 months in anesthetic training, and that's really happening nowadays. They know how to get this block done properly. They do the stop sign, or they stop before you block, and they do every safety precautions before they proceed. So fascia iliaca block gives you a very rest of mind because they give you very good pain relief. So medical history in the preoperative assessment, it could be, as I said, good 68 who is fit and healthy, no real issues, or could be very poor 68 with a stroke, atrial fibrillation, left with multiple comorbidities, renal dysfunction, liver dysfunction. So it could be a very bad 68. So again, the chronological age is not the matter. It is the biological age in your assessment that counts. History of the event, the type of fall is very important for us here. Did this patient, did she fall because she was fasting and hypoglycemic, or did she have a seizures episode? So I need to investigate that. Maybe she has a stroke as well, and we didn't discover that. Could it be acute myocardial infarction, or could it be the arrhythmias? She had tachyarrhythmias. She has a known AFib. Is it a tachyarrhythmia? So you need to figure out with discussion with your patient what was the leading cause of this fracture. Okay, so again, you have to highlight the previous mobility. Was this lady, as we've seen, she was going to make wudu, so she was depending on herself in this scenario. So like this is not a question in this exam scenario or in this scenario. So she is taking care of herself. Examination is a cornerstone before you go towards theater, as in every case, but we need to highlight few things in this scenario. So focused exam depends on the history of this patient. So if this patient 68 and hypertension and AFib, I need to auscultate this patient heart to find any murmurs. Maybe there is an aortic stenosis. There may be any other heart murmurs. You need to examine the lungs for any pulmonary edema or pneumonia. With this age group, they may develop a heart failure because of the pain and tachyarrhythmia. So diastolic dysfunction and oxygen demand supply mismatch with the tachycardia may precipitate a heart failure. So please auscultate your patient carefully before you push him to anesthesia theater. 35% of these patients has at least one comorbidity, and take this comorbidity and try to investigate it more. If it's cardiovascular or CNS or respiratory, focused exam and then investigate accordingly. Renal impairment is mandatory, so you have to investigate the kidneys. Please check for any problems with the abdomen. Maybe this patient with the fall, she had any trauma or any bleeding in the abdomen. So put your hand on the abdomen, confirm there is no bleeding, or there's no, this tachycardia is not due to intra-abdominal hemorrhage or shock state is like this 195. Definitely she is not an obvious shock, but again, it could be a cryptogenic shock. Cryptogenic shock means it's at the level of Krebs cycle. So maybe this patient is anemic, she's losing blood in the abdomen, but because of the pain and the stress, her blood pressure is still overshooting. And you need to investigate that more before you proceed and push a spinal anesthetics or general anesthetics to this patient. And at this moment, you will really lose the game because you lost the compensatory mechanism. So again, if your patient is showing any signs of anemia or hypovolemia, you can resuscitate him. You have to resuscitate him before you proceed to the clinical anesthesia scenario. So this is a job of all. It is not the job of anesthetist. So emergency physician, orthopedician, they all know how to resuscitate patients. But be careful. We're not targeting a super high hemoglobin or overzealous blood transfusions for this case. And again, fluids should be limited because this age group, again, he is hypertensive. I'm not expecting his diastolic functions on the echo to be the best, so your fluids may cause the pulmonary edema. So how to monitor that? Again, you can use the X-ray or ultrasound, but go clinical first, listen to the chest. There's no pulmonary edema, saturation is maintained, patient is not tachycardic, so sorry, the patient is not tachypneic or distressed. All this will be a bit assuring for you. DVT prophylaxis, if you admit this patient overnight, so this patient is going to happen tomorrow's list, please give him low molecular weight heparin prophylaxis dose. Otherwise, DVT and PE carries a lot of comorbidities. So continuing to preoperative assessment and management, what are the investigations I should ask for? So full blood count, and I need to look at the anemia, so hemoglobin. The AAGBI guidelines says if the patient is ischemic heart disease, your hemoglobin should be above 9. If no ischemic heart disease in the background, you are accepting anything above 8, but nothing less than 8. So if your hemoglobin is less than 8, you have to transfuse him prior to bringing him to anesthesia theaters. The platelet count, and it should be, if you are giving a neuroaxial block for this patient, at least 80. So this is important for neuroaxial blockade. If you have low platelet count, this is not a rationale to postpone this case or wait for the platelets. You can give him a GA, and we'll discuss that in a minute. Okay, so leukocytosis, this could be reactive because of this stress-induced condition, and this is acceptable unless there is like fever and sepsis and high lactate, and it's completely different kettle of fish. So the second is group and hold. Every patient should be cross-matched for 2 units. Urea and electrolytes, expect this patient, if you are in our countries and the patient was fasting, some electrolyte disturbances, dehydration and hypernatremia, so you need to give some fluids for this lady, or hyperkalemia because of renal impairment joining this age group. Coagulation studies are not routinely used for these patients, so don't ask for a routine coag unless you have an indication. And in this patient in particular, we need to do coagulation study to see what is our INR. This brings us to what is the INR that I should operate on in this patient. For neuroaxial blockade, you need to be less than 1.5, and for the orthopedic surgeons to work on this case, they need to be less than 2. So ECG, every patient going for this fracture should have an ECG, even if he's young, as per AAGBI guidelines. And why the ECG is for, number one, for the arrhythmias, to detect any arrhythmias, for any left ventricular hypertrophy signs in the ECG, and third one, if you have with this severe pain, any ST segmented changes that should be taken into consideration. And if there is any suspicion, make an urgent cardiology involvement or liaise with the cardiologist to ask him, what do you think, should we go first to cath lab, or it's like oxygen demand supply mismatch, or we call it a type 2 myocardial infarction. So we need to optimize the tachycardia and hypovolemia, then head towards the theaters. So chest X-ray is not routine unless there is an indication on the clinical. And I am happy to say, because I'm teaching lung ultrasound, that lung ultrasound is more sensitive and specific in these scenarios compared to the chest X-ray. So if you learn lung ultrasound, I may refer you to my lectures on lung ultrasound to see how to differentiate between pulmonary edema, pneumonia, what's the difference between A lines and B lines and AB lines or AB profile. So it's easy. Once you do 10 cases, it's enough. So you can use the ultrasound. There's a lot of handheld devices now you can use in emergency department and see, okay, like this is a pulmonary edema, we need to diurese him, or this is a pneumonia, we need to give him antimicrobials. So please take 5 minutes on one of these lectures. I think you will get a benefit. So now, if the patient is diabetic, you need to get a random blood sugar and correct the hyperglycemia, but it is not an indication to postpone this case if the patient is hyperglycemic, unless unless he is ketotic or massively dehydrated and there's ketones in urine. So you need to postpone him for the DKA management before, and you have to consult the endocrinologist to do that. Atrial fibrillation rate below 120 is not a contraindication to proceed for surgery. We talked about anticoagulation in the term of warfarin and cutoffs, but the platelets, antiplatelets, aspirin should be withheld during the stay unless the patient has an angina or a stroke. Otherwise, if there's angina or stroke, continue antiplatelets. Clopidogrel, there is no recommendation. Actually, there's a recommendation against stopping the clopidogrel, and you don't need to transfuse him any platelets. So please go ahead, particularly if this patient is ischemic heart disease and he has a drug-eluting stent. At this moment, you cannot stop his clopidogrel. Try to avoid the neuroaxial blockade, and you can go for GA in these cases if you are concerned with antiplatelets in this occasion. So heart murmurs and echo, as I said, echo is not to assess only for the heart murmurs. It's to assess the regional wall motion abnormality as a guide, plus the ECG. If there's any ongoing myocardial ischemia, is it type 1 or type 2 MI? We need to refer and liaise with the cardiologist. You need to assess the diastology, because this is what pushes you into heart failure, and this is what actually increases your mortality. You need to investigate for any cause that caused this syncopal attack. If it is the reason for this patient to have the fracture neck of femur, you need to do carotid Doppler, and you need to do echocardiography assessment to see if there is any aortic stenosis or carotid artery stenosis as a cause of that. Because once you put this patient asleep as a GA, you may wake him up, unfortunately, if you didn't investigate that, with a stroke. I'm not following the time accurately. Please warn me in 5 minutes before I finish. So in ICDs or implantable cardioverter, defibrillator, and pacemaker, it is mandatory to refer as early as or as soon as possible to the cardiologist or the cardiophysiologist to get a check on your implantable cardioverter device and put a plan, clear plan for you. What is the time I will stop this one when I'm coming back? And like this should be in agreement. Again, it's part of the team assessment, is the cardiophysiology involvement in this one. So if the patient is going to theaters and we are using a defibrillator inside theaters, we need to stop the pacemakers, but we cannot stop the cardioverter device. And like if you have any queries, you have to have the magnet. You need to get the check of the ICD and when it was inserted, what was the indication, and when is the last check, and is it proper, when is the last check time. All this data you have to have before putting this patient asleep. If you remember any slide from this lecture today, this is your slide of concern. So what is the acceptable and non-acceptable cut-offs to postpone versus proceed with this patient? Unacceptable to say there is lack of facilities in this patient. Unacceptable to say I am waiting for an echo because this patient has a systolic murmur. I don't have an operating theater for that. It's a protected theater. You cannot use it unless it's a life or limb. It's any minor electrolytes cannot be your rationale to postpone this case. So hemoglobin less than 8 is unacceptable. You have to transfuse blood, but it takes you 2-3 hours to transfuse blood. So you're still in the 48 hours window. If your sodium is less than 120, particularly if it's symptomatic hyponatremia, you have to push the sodium above 20, then proceed with theater. This is as per AAGBI guidelines. Potassium less than 2.8 is contraindicated, acceptable to postpone the case, but please put a central line and correct his sodium quickly and push him to theater. So it is postponing, but within the 48 hours period. Potassium, if there is a renal impairment and this patient needs dialysis, okay, go ahead, dialyze him or give him anti-hyperkalemic measures, correct him quickly, then push him to theaters again. If the arrhythmias with a ventricular response more than 120, you need to control the arrhythmias before you proceed to theater. Otherwise, it's fine. Go ahead. Reversible, any coagulopathy is reversible. You can reverse that with the vitamin K, with fresh frozen plasma. If it is argatroban or dabigatran, there is antidotes for that one. So you can give vitamin K and the prothrombin complex as a treatment for that. So this is the time you need to use all your tools. If there is a chest infection with sepsis and septic shock, you have to prioritize patient life versus the neck of femur. If it's uncontrolled diabetes, again, you can control that, but don't postpone the case unless he is in DKA or severely dehydrated. Intraoperative management, again, let's go to the choices of anesthesia in this case. Is it neuroaxial blockade, general anesthesia, or peripheral nerve block plus one of these other two options? I think so far there is no any evidence or a minor evidence that using any technique versus the other. 5 minutes, thank you. So there is no or little evidence supports any of the other techniques. So you please use what you are familiar with, but don't combine general anesthesia and spinal anesthesia together, because it will be a more profound hypotension. And if you're going for intrathecal anesthesia, use just 10 milligrams of bupivacaine, like 2.5 milliliters, because this reduces the incidence of hypotension. You can use selective spinal anesthesia with plain bupivacaine with the fracture side on top to minimize the hypotension. If you're using narcotics in your spinal or intrathecal anesthesia, please use fentanyl rather than morphine, because it is less depressant for the respiratory system. If you're going for general anesthesia, use narcotic-based anesthesia with short-acting narcotic drugs, and you still can use the inhalational anesthesia. AAGBI guidelines says that inhalational anesthesia is very well tolerated with this age group, with very good hemodynamic stability inside if you're using that. Peripheral nerve block comes back. If you didn't give the peripheral nerve block in the term of fascia iliaca block or lumbar plexus block in the emergency room, you can do that as an adjuvant. It decreases really the pain happening after surgery. So the most optimum and the best choice will be the lumbar plexus block. It should be happening in theaters only, versus fascia iliaca block, which is not a bad choice. You can do that in emergency room, particularly if you are trained enough to do that with anesthesia team. And femoral nerve is not enough. You need to know that the femoral nerve is blocking just one nerve out of the three, so we need the obturator and the femoral nerve. And one third nerve, I forgot the name, I'm sorry for that. Monitoring, you need to monitor your patient as per the AAGBI standard, which is an anesthetist inside the room. You have to have a pulse oximeter, end-tidal CO2, ECG, that's all the routine, non-invasive at least, and point of care hemoglobin. This is one extra added for this kind of surgery, because you're expecting blood loss. In these cases, you are expecting blood loss, so you have to have point of care hemoglobin checks, and some optional depending on your patient. If I were you in this case, in our particular case, in our case scenario, I will use invasive blood pressure monitoring. If I have any invasive cardiac output monitoring, I will use it, particularly if I'm putting this patient under general anesthetics. If I have a bispectral index for delirium and the postoperative delirium, I will use the bispectral index to guarantee that my patient, if he is paralyzed, and there is no consensus that this patient should be paralyzed or spontaneously breathing, so there is no recommendation from AAGBI guidelines in that regards. Cerebral oxygen saturation is used as well. Intraoperative management, this patient should be pain-free all the time. Don't use non-steroidals, use paracetamol as routine. Codeine is recommended against by the AAGBI guidelines. Thromboprophylaxis, you have to have low molecular weight heparin in the evening before surgery because you are preventing DVTs in this patient. Stocking and intermittent compression devices should be used intraoperatively. Antimicrobials, as all surgeries, should be given within the first hour, within 1 hour or 60 minutes from the skin incision. And please remember the pressure areas should be protected and no angles more than 90 degrees if the patient is under GA. Otherwise, you will find some complications after surgery. Thermoregulation, again, use your bear hugger or huggy bear, whatever you call it, but you have to keep your patient warm. I'm not going to talk about hypothermia and its implications on the coagulopathy and in the electrolyte disturbance and in the recovery and delirium. All that stuff is going to be discussed in separate lecture. IV fluids, keep your patient is hydrated, but if you had the point of care ultrasound and you found diastolic dysfunction grade 2 or grade 3, be cautious with fluid management. Nursing, this as per the AAGBI guidelines, you need to have 1 to 4 nursing care in the post-operative ward, no less than this, otherwise your mortality will be higher. Analgesia, paracetamol regularly, patient-controlled analgesia with short-acting opioids. If your patient is a bit delirious, use nurse-controlled analgesia. Keep your patient on oxygen for the first 24 hours as per AAGBI recommendations. Early mobilization, improve oxygenation and respiratory functions. So be keen to get your patient out of bed as fast as you can. Fluids, again, you have to prescribe this patient for IV fluids in the 24 hours or as soon as he starts his PO intake. Be again legitimate, be again vigilant to start feeding for this patient as quick as you can. Urinary tract infection is one of the issues, so please, if you need to put a Foley scatter, remove it as quickly as you can. This patient has benign prostatic hyperplasia in most of scenarios. If you have post-operative delirium or confusion, you need to treat that very quickly. Lorazepam is your drug of choice. Haloperidol may be a good choice, but you have to give him something. I'm in the last slide now. Malnutrition, please liaise with nutritionist to give him good nutrition in the perioperative period. Rehabilitation as quick as you can, minimize the post-operative complications. So back to our clinical scenario, this patient is 68-year-old female, non-insulin dependent diabetes, so control the blood sugar, but don't postpone unless she is, again, I'm repeating this quickly, but unless she is DKA or severely dehydrated. Hypertension, control the pain first before you control the blood pressure. If the patient has ischemic heart disease and atrial fibrillation, be keen to continue on the antiplatelets, particularly if she has a dual a drug-eluting stent. You have to check INR in this case, or coagulation profile in this case, and your target INR less than 2 and less than 1.5. The first is for surgeon, the second is for neuroaxial blockade. And if this patient is having a saturation of 94%, please put your ultrasound probe quickly on the chest after you examine her, see if there's any pulmonary edema, does she need diuresis, is there any pneumonia, we need to start antibiotics, and this could be the blood sugar. If the blood sugar is going higher and higher, you have to liaise with your endocrinologist, like this patient next blood sugar was 16.5, that's 490, and she's fasting for Ramadan, did we give her anything? So this is it, is it stress-induced? We need to liaise with our endocrinologist, optimize the patient. These are my references, and thanks so much for listening. Sorry if I'm a bit behind time.
Thank you. Dr. Walid, I think I want to be able to be a moderator again. We are so lucky that we have 3 exceptional lectures. We can stay here more time to listen to all those speakers. I think I would like to thank Dr. Walid for his contribution today, for exceptional pathway for fracture neck femur, and in that way it's really very good. I would like to take some questions here. First question for Dr. Assam. Just to get Dr. Assam, is he here? Yeah, okay. Yes. As it continues post-operative in ICU, till what time, especially if no toxicity, one more protocol for BCE? A protocol for BCE and craniotomy?
Yeah. I saw 2 questions to me, one for the PCA and one for the magnesium sulfate. I'll start by the magnesium sulfate. Very nice drug. I like these drugs to be delivered for any patient in anesthesia, for any surgery, and especially for the neurosurgery, for the spine surgery. Magnesium sulfate, as you know, it is given with very high dose in obstetric, mainly in obstetric, to control for eclampsia and preeclampsia. And we are using magnesium sulfate in the surgery, especially in neurosurgery, with very minimal dose. It doesn't lead to any side effects or muscle relaxations, but it gives us the privilege of sedation, analgesia, and a lot of advantage for the patient post-operative. We are giving the protocol intraoperatively with 1 dose as a bolus dose of 20 milligram per kg, 1 dose, and this should be given after induction of anesthesia. Why? Because magnesium sulfate, it has a vasodilatory effect. It can cause some of the burning. So if you are doing research work on magnesium sulfate, don't give magnesium sulfate. Double-blind study will be biased, and the patient will feel that something had been given, and he will feel with irritation at his hand and some of the burning and flushing. This is one thing. After giving dose of 20 milligram per kg as one bolus. After that, we infused immediately with 10 milligram per kg per hour. This total amount of magnesium sulfate is very, very minimal, but it helps us a lot. And be cautious when you are giving magnesium sulfate. Don't give magnesium sulfate for 2 patients. The heart block, because it aggravates the heart block, and for the renal impairment patient, because the magnesium sulfate is excreted through the kidney. So be cautious about this magnesium sulfate. Related to the PCA, as usual, the protocol as usual, we are giving either fentanyl or morphia, but better for the craniotomy itself to give fentanyl because it is less vigorous than the respiratory suppression like morphine. And we are giving, as you know, according to your institute protocols, in our institute protocols, we are diluting. We have the cartridge to be dilute PCA 300 mic or 500 mic in 50 or in 30. So the strength will be 10, the dilution will be 10 mic per ml, and to be delivered with look out time with the 6 or 10 minutes as you like, maximum per hour, no more than 100 mic of fentanyl.
Okay, thank you very much, Dr. Assam. There's another question from Marwa, Dr. Marwa Saeed. In patient coming with cervical fracture associated with spinal shock, do you routinely wait until spinal shock resolves, which may take weeks, or you will ask for a pacemaker, which, for instance, treats significant bradycardia preoperatively?
Yes, this is a very important question, and I think this spinal shock, this is a decision of the neurosurgeon or the people there in the emergency department. And as you are receiving the patient, you should evaluate the patient. If there is emergency and there is something hurting for the patient and cannot stay for without surgical intervention, you should call for as emergency, and you should request for a multidisciplinary team to help for application of the pacemaker, no matter of that. And you cannot detail the surgery for avoiding more deterioration for the patient.
Thank you very much, Professor Assam. Thank you very much, everybody. And I'm not sure, is any question for Dr. Walid, Dr. Hisham?
Okay, there is one question here, came to me from Hisham. Is there any advantage on fascia iliaca block over femoral nerve block? And this question is coming from the YouTube channel. So yes, so the AAGBI guidelines recommends if you're using nerve blocks for these cases is either lumbar plexus block or fascia iliaca block. Femoral is covering just the femoral nerve. It's not covering the obturator nerve, or the third nerve that I forgot the name actually. So I'm not a regional anesthesia guy. I know to block the major blocks only. One of them is the fascia iliaca block. So you can do that blindly or ultrasound guided. It's a simple block, and it's actually the same approach of the femoral nerve block. It's just different location and ultrasound guidance. So if you do femoral nerve block, you can do the fascia iliaca block, provided you get the training enough. So it is just a field block. So fascia iliaca block is a field block. Femoral nerve block, you're just blocking one nerve, which is not enough coverage, because the neck of femur is covered by the femoral nerve, but the incision site needs to expand your incision more behind the femoral nerve skin coverage.
Okay, I think I will take the chance, because I'm a moderator for this session. I may take the liberty to ask one question, if you don't mind me. In patients with fractured neck femur, they are coming to theater in severe pain. And what do you give them for positioning to give the spinal, if you don't mind?
Perfect. I'm really happy that you asked this question, Prof. Saad, because this highlights what I say.
For patient.
So the patient should have the fascia iliaca block from the emergency room. If we are talking what should happen ideally, because you shouldn't leave the patient to arrive to theaters in pain and start from the anesthesia induction room. So this is the number one. If the emergency physician is not free or he's not trained enough to do that, they should give him some supplemental analgesia in theater, in ER, and once he arrives to theater, I will give the fascia iliaca block. This is one option. Sometimes we do the femoral nerve block just for positioning. Okay. Sometimes what we do is a 25 mics of fentanyl to maximum of 50 mics of fentanyl, provided the patient has no major contraindication for that from respiratory perspectives, put him on oxygen, and I do myself to position this patient fracture side up and give him plain bupivacaine and then leave him, because this is the position of the surgery. If they are operating on the fracture side, it's better to leave him in this side rather than giving him heavy bupivacaine and put the fracture side down, causing more pain. And once you are inside theater after 15 or 20 minutes, you again reposition the patient to make the fracture side up. So again, 10 milligrams of plain bupivacaine gives you very good controlled blood pressure. It gives you good analgesia intraoperatively. You don't need to reposition the patient, and it really works for me very well.
Okay, certainly right. And the other thing is, do you have experience in ketamine for positioning?
I don't usually use ketamine, Prof. Saad, above at this age group. So I am really worried about delirium and in the post-operative period. So even if it's a small dose with a patient who presented with systolic blood pressure 195, he's hypertensive, if we're sticking to the scenario, and I'm expecting him to be delirious with some renal profile impairment or renal kidney disease, I wouldn't rush to give ketamine in this patient unless this is my only choice, but I don't think you have only one choice. Just one point I forgot to mention in the lecture, but it's really essential for everybody to know. I mentioned it, but I didn't explain why. Look at the patient previous mobility status, because if she is a bedbound, this may be on its own an indication not to do the surgery unless you need to do that for pain control. So here, the emergency procedure changes into semi-elective procedure. If my patient is not walking before this fracture, I may still do the surgery for pain control, not for mobility issues. So I wouldn't be really considering that fracture neck femur as an avascular necrosis and that stuff.
Here we should finish because now we are almost.
I have a question, Dr. Saad.
2 hours and a half.
I have a question from Dr. Hisham. Excuse me. He is asking about in craniotomy, surgeon insists to keep systolic blood pressure below 100. Can I ask, or if there is?
Yeah, you can go ahead now, feel free.
Okay, thank you, Dr. Hisham. This is very, very, very interesting and very common question intraoperatively. And believe me, the surgeon is not aware from what is going in the anesthesia. So, and you should manage your patient ideally. And as I said in the lecture, the important item of controlling bleeding, believe me, is not the blood pressure, even in ET surgery. But there is a belief, a common belief, that induced hypotension decreased the bleeding. It is a wrong conception. The determinant factor who decrease the bleeding is heart rate. We should keep the normal blood pressure, the normal mean blood pressure as normal, 100 or even above 100, for keeping the perfusion of the spinal cord and for the brain, and to manipulate and play with the heart rate. If for example, your heart rate is 50 or from 50 to 60 and blood pressure, mean arterial blood pressure is 100 or above, believe me, the surgeon will not suffer from any bleeding, and you will keep your patient in the safe side. Thank you.
Okay, thank you very much, Dr. Hassan. And by this time now, I would like to conclude the session. And all of us
We have
will...
one question, Dr. Saad. Yes, we still have one question. Dr. Samir asking about calculation of the gap.
Okay,
difference.
I haven't seen it.
Yes, so please, Dr.
I'm sorry, I haven't seen it. My apology.
Yeah, no
How to interpret gap difference?
Gap
Yes.
difference.
Okay, I see it here. Yeah.
Delta
Okay,
gap.
the osmolar gap or anion gap?
Delta gap, if you want to measure the delta gap ratio between the excess and anion gap divided by the deficit in bicarb gap. Excess of anion gap divided by the deficit in bicarb. This meaning, if anion gap, normal anion gap 12, you have to subtract 12 from the value you have now, divided by 24, which is the normal value of bicarb, minus the new bicarb level. I wanted to comment on some point about ketamine and post-operative analgesia and analgesia and ICU. Really now recently proved ketamine is antidepressant. If you give to your patient, it will ameliorate depression within immediate and for 2 weeks at least. And it is proved to decrease the analgesic doses of any drug we use or consume during the operative or in the post-operative state. Ketamine, one of the drugs now for potentiating the analgesic drugs. I know it has many side effects like excessive salivation, tachycardia, increasing blood pressure, hallucination, and so on. But if we supplement it with some small doses of benzodiazepine as dormicam or lorazepam, it will ameliorate the side effect. But it is a good drug and beneficial drug in ameliorating the requirement of analgesia in the post-operative and intraoperative situation for period.
Totally agree, Prof. Samir. For the last 12 years, I'm working in trauma theater, and most of my patients with fractured femur, fractured neck femur, for positioning, I give them 0.25 to 0.3 milligram per kilogram body weight ketamine for positioning, plus 25 mic of fentanyl, and it is amazing. No respiratory depression, oxygen mask monitoring, and you don't feel anything for positioning. And once you have the spinal, everything will be perfect. And it is very good.
So if you allow me for a small comment on that, like everyone has his own experience and his own way of doing things. If we are doing,
that's right.
Yeah, if we are talking about AAGBI guidelines, we have to differentiate that between saying my experience is like so and so. So when I was asked the question, I was saying my experience, and my hospitals, the hospitals I worked in, they omit that completely from the practice. They hate giving any ketamine above 65-year-old, particularly with the delirium and hallucination, particularly if combined with the midazolam. So I'm not saying that is wrong, but like AAGBI guidelines didn't say anything about that to my knowledge.
Sure. Thank you very much.
Thank you.
Thank you very much again for your exceptional time, 2 hours and a half today in our program. And we are so proud to have 3 top speakers, Prof. Samir Ansari, Prof. Hassan Manna, and Dr. Walid Alhabashy, 3 exceptional lectures. And I'm sure the scientific meal today is huge. And I really enjoyed listening to all the 3 speakers. Added very good knowledge to me today, and I'm sure everybody has enjoyed the lectures today. Thank you very much, everybody.
Thank you. Thank you so much.
Thank you.
Thank you very much.
Thank you.
Bye-bye.
Bye.
Thank you.